Well, thank you so much, Vida, for inviting me to speak here in this conference. As she said, I'm in Kansas City, so it is always a special treat to come over to Europe and spend some time here. So I'm going to expand on what Magnus has presented, the pharmacogenomics-based personalized drug treatment, and give you a little bit more insights across world populations. And so my objectives today are to talk very, very briefly about pharmacogenetic resources, because I will talk more and go into detail tomorrow in a workshop at 3 o'clock in the afternoon. So I will just give you a very brief introduction into these resources, which I will cite throughout my talk. And then talk about pharmacogenetics and dose-independent adverse drug reactions. So these are HLA-mediated, and then go into pharmacogenetics and dose-dependent adverse drug reactions. And this is where all the cytochrome P450s and transporters are, as we heard earlier from Magnus. And then I will wrap up my talk with an initiative at my own institution, which we call GOLDILOKS, to show you how we are going to improve drug treatment for one particular gene drug pair as a model to move forward. So I call this the Triad of pharmacogenetic resources. So you have here the Pharmacogene Variation Consortium, which I'm heading, and this is came out of the cytochrome P450 nomenclature site, which Magnus launched about 18 years ago now, at the early 2000s, and which was transitioned to PharmVar a couple of years back. And so we are expanding now beyond P450 genes to include other pharmacogenes. Then we have the CPIC group and PharmGKB. So what is CPIC? So this is an international group of over 300 members composed of clinicians and scientists. And you can see this is really an international group. And this consortium has individual volunteers and a small dedicated staff who are interested in facilitating the use of pharmacogenetic tests for patient care. And so the major goal is to come up with guidelines that are designed and written to help clinicians understand of how to use and interpret genetic test results to optimize drug therapy for the individual patient. So these guidelines are not recommending whether you should order a test, so this is still up to the clinician, but help and give the physician and clinical team all the information they need about the genes to translate the genetic information into clinical action. Then the PharmGKB is one of the foremost resources for pharmacogenetic information. And so they are doing extensive work on curating the primary pharmacogenomic literature, extract the knowledge, aggregate the knowledge, work towards the clinical interpretation, and then towards clinical implementation. So if you are interested in pharmacogenomics, you need to know PharmGKB, so please go there and check out this wonderful resource, which is located at Stanford University. And so they, as I said, curate genotype and phenotype data for these dosing guidelines and work very closely with the CP group and also with the PharmVar consortium. And so here for the PharmVar consortium, so we are a central repository for pharmacogene variation to then enable the other groups to take that information and translate it into clinical action. I'm not lingering on this page here because Magnus already gave you an introduction into this European initiative, the ubiquitous pharmacogenomics undertaking here. So going to talk a little bit about these dose-independent or idiosyncratic adverse drug reactions. These are usually causing severe cutaneous adverse drug reactions. These can be fatal. These are unpredictable. They often only occur weeks or even months after the drug was initiated, and they are rare in most populations, and so they are often not discovered during drug development, but only after the drugs have been approved. Here I'm just showing you a selection of drugs that are causing ADRs. So you see here, and I'm talking a little bit more about carbamazepine. So this is an anticonvulsive, so is phenytoin here. Bacavir is an antiviral that is often used to treat HIV. Allopurinol is a drug to treat gout, and there are a number of others, and those I have highlighted here in blue. There are CPIC guidelines available, and you find these guidelines free from the CPIC website. So just go to the CPIC site and you have free access to all these resources. There are a number of underlying models causing these cutaneous reactions, and they essentially just differ in how the drug or metabolite are presented to the immune system. So these are believed to be CD8 T-cell mediated reactions, and for the interest of time, I cannot go into details, but I would like to refer to this wonderful review article should you be interested in finding out more. Now, this is really a beautiful Manhattan plot, and I want to really draw your attention that this was done with only 53 patients. I mean, this is astonishing, but also possible because of that very well-defined and extreme phenotype, and of course, a monogenetic reason. And so this is one HLA locus in Japanese for a carbamazepine, and so these for carbamazepine, there are actually two loci that are causing these adverse reactions. The one I showed you on the previous slide for Japanese. However, the one that is more commonly causing these is HLA-B star 1502, and you will notice that this here is different from the one I pointed out here. And very interestingly is for this particular locus, this is highly common in Chinese with over 20%, in some other Asian countries between 10 and 20%, but it is rather low in Japan. But the other locus I just showed you on the GWAS is causing most of these drug reactions in Japanese. So you already get the idea that it is very important to know what to test in these different populations if you want to get to the underlying genetic variability causing those. And then for abacavir, we have a very similar situation that the frequency of this particular HLA locus is also really varies significantly across these world populations. It has been shown in Thailand where the HLA testing is now paid by the government, that the incidence is going down. It shows here up to June in 2016, and the data are trending further down. So definitely preemptive testing is really doing its trick here in preventing these really serious adverse reactions. Now, it's not only cutaneous reactions that we can see. So flucloxacin is an antimicrobial agent which is causing drug-induced liver injury. And again, a beautiful Manhattan plot with one peak done on 51 patients and not even 300 controls. So these are very telling. However, because these reactions are rare, it can sometimes really take time to get even 50 well-defined patients together to do these kind of studies. Now, only this year, about 3 or 4 months ago, it was published that vancomycin, which is a commonly used antimicrobial, can also cause adverse drug reactions. And interestingly, this occurs in about 7% of individuals in Europeans. However, only 20% of those are actually having these adverse reactions, which can cause also rash, but renal impairment and so on. And it is also observed that these often or most commonly occur with a combination antibiotic therapy. So there are also other triggers in addition to the HLA underlying genetic predisposition that can cause these reactions. And this is really very new work from my own institution, which was just published. And so this is about Trimethoprim-Sulfamethoxazole, or Bactrim in short. And so this is a very commonly prescribed antibiotic, for example, to treat acne or urinary tract infections. It is known that this causes cutaneous reactions and hypersensitivity syndromes. But in 2018, we have seen a 16-year-old female with pulmonary failure of unknown etiology who needed ECMO support. So you see here this girl who was actually featured in a story by CNN in which our suspected or the suspicion of an ADR to Bactrim was not mentioned. And after it was aired, patients and parents came forward to us and reported their own cases. And so that was actually quite interesting. And so we have now reviewed or been made aware of about 10 cases. 5 of these cases were just published in Pediatrics, and 2 of these 5 cases were fatal. And so this girl sadly passed away about 2 months ago. She virtually lived in the hospital for about a year, just to give you an idea of how dramatic and sad these stories can be. And we do not know whether there is an HLA involvement. We certainly think there is, but with 10 cases, I'm not sure whether we can do a GWAS quite yet. So we need more patients, and so please, if you know of any, direct them to us. Of course, the question is always cost versus benefit. And so one group developed a methodology to determine the value of PGx panel tests, and they have done that on these HLA loci. And overall, they found that testing these is cost effective, at least for those when it's directly acted upon. It was not cost effective for initial use on carbamazepine on one of the loci and allopurinol, but these are the most rare ones. But on the other hand, we are really talking here about precision medicine or individualized drug therapy. So if I had to take any of these drugs, honestly, I don't really care whether it's cost effective. I just don't want to have any of these drug reactions. And these tests in the end are really not that expensive. And so I think there is really a responsibility to test everybody for these reactions to avoid them, because they are just so devastating. Now I'm switching over to pharmacogenetics and dose-dependent ADRs, and we have already heard quite a bit from Magnus before. So here on the right, I have listed a number of adverse drug reactions. This list is not comprehensive. Treatment failure is one of the main adverse drug reactions. We sometimes don't call treatment failure an adverse drug reaction, but it really is, because people are taking a drug and it's really not helping. This graph here is taken from a recent publication by Busman, graphically showing really all these different drug classes where there is a pharmacogenetic component. And we have heard already for 2C9 and warfarin, 2C19 and clopidogrel. I also want to point out really quickly about thiopurines, which are anti-cancer agents, NUT15 and TPMT. These can be fatal if these defects in these drug metabolizing enzymes are not recognized. The same for DPYD and fluorouracil. But antipsychotics and antidepressants are drugs that are increasingly used, and where especially 2D6 and 2C19s are major contributors. And so I want to give you an example for 2D6 because that is undeniably my favorite enzyme. And so I'm giving here a number of drugs. Again, this is not a complete list. And here on the right, all these red highlighted ones are drugs where 2D6 is either the major pathway or contributing to it. So you can see it's in pain, antipsychotics, antidepressants, ADHD, some cardiovascular drugs, but and also an anti-cancer drug, which is tramadol, which is still a staple in estrogen-positive breast cancer. So quickly about codeine. So there was a relatively famous case, I want to say, published in 2006, even on the front page of the Toronto Globe and Mail, and this is why it's also often referred to as the Toronto case. And that was another really sad case, one of the saddest I was involved with. So this woman gave birth and took codeine and acetaminophen for obstetric pain. And her newborn actually had a fatal opioid poisoning and died at the age of 13. It was shown that there was high morphine levels in breast milk. So this is going through breast milk to the baby, and the baby, because it's so young, does not have these drug metabolizing enzymes already in place. So there was these high level of morphines that suppressed the breathing, and so the baby essentially just suffocated and passed away. And the mother was genotyped as a 2D6 ultra-rapid metabolizer. So this explained these high morphine concentrations in the breast milk, and you have to be aware that codeine itself is inactive. It needs to be bioactivated into a morphine derivative to get benefit from the drug. There have also been a series of codeine fatalities after tonsillectomy. So if you take your child in for day surgery to take the tonsils out, you certainly don't really expect your child dying because it took codeine to help with the pain, but it did help, but it did happen in a series of cases that, again, it was breathing suppression in a number of children who were genotyped as ultra-rapid metabolizers, and the FDA then reacted by issuing warnings and contraindications for codeine. However, codeine can be prescribed safely in children, as shown here by the dosing algorithm St. Jude is using, especially in sickle cell patients. So sickle cell patients take codeine intermittently to help with these painful episodes for sickle cell. And so they have come up with this algorithm. So if codeine is prescribed, the question is asked whether it's a tonsillectomy, and if yes, avoid codeine. If no, is the genotype known? And if it's an ultra-rapid metabolizer or a poor metabolizer, avoid codeine. But if you have a normal metabolizer or an intermediate metabolizer, codeine can be used as recommended. And they have, when this was published in 2016, shown that codeine can be safely dispensed even in children using that pharmacogenetic information. So there is plenty of evidence that really shows that implementation works. There is a CPIC guideline for 2D6. This was actually the second guideline ever written in 2012. It was updated in 2014, and we are currently working on yet a new update, not just on codeine, but also a guideline that includes other opioids. For 2D6, there are also a number of other guidelines available for SSRIs, tricyclic antidepressants, antiemetics on ondansetron and dropezitrone, then for tamoxetine, and one that just came out for atomoxetine earlier this year. You have already seen this here by Magnus. So this is a wonderful graph that really shows the relationship between the number of active copies and nortriptyline dosing. And so for the ultra-rapid metabolizers, the recommended daily dose is about 5 times higher compared to the dose that is recommended for these poor metabolizers. The relationship between codeine metabolism and 2D6 genotype has also been shown for codeine, and our own work has shown it for atomoxetine, where you see here in red are the poor metabolizers. They have much greater areas under the curve or levels of atomoxetine in plasma compared to the intermediate metabolizers and normal metabolizers. And I will come back to this here a few slides further in. Now, just to show you the phenotype distribution, this here is shown for Caucasians. So you can phenotype entire populations by giving them a probe drug and measure the drug and the metabolite in urine after, for example, 4 hours. And so the poor metabolizers, they have the bulk of the probe drug unmetabolized in urine. So these are here the extreme phenotype, the poor metabolizers. On the other end, the ultra-rapid metabolizers have in that short period of time metabolized most of the dextromethorphan into dextrorphan, indicating rapid metabolism, and then you have the normal and intermediate metabolizers in between. And depending on what your genetic patterns and variants you have in a population, this histogram can have different forms. So if you have more of decreased function alleles, this histogram shifts to the right, so you have more intermediate metabolizers. We have already seen some data for the ethnic diversity of 2D6 activity. And so with these data, we have taken the genotypes from an extensive literature search and translated or inferred activity from genotype. And what you can see here for these poor metabolizers, there is considerable variability among populations. So in Caucasians, it is between 5 and 10%, but in Asians, East Asians, it is usually 0 to 1%. On the other extreme, the ultra-rapid metabolizers, again, you see extreme variability. It's about 1 to 2% in Caucasians, but it can be quite high here in Oceanian and also some East African populations. And you see it essentially for any genotype group in between. Now, the PharmGKB has just recently proposed a slightly different biogeographic grouping system for pharmacogenetic population annotations, grouping individuals as shown here on this world map. One really challenge was, where do we want to put these, especially Near Eastern North African populations, because they didn't really fit in with Caucasians. They are definitely not fitting in with the rest of Africa. And so this new population grouping is used by the PharmGKB as we move forward. And all these frequency tables that are maintained by the PharmGKB and used by the CP groups have been switched over to this new biographical grouping. And here on the right, you can see for this CYP2D6*10 allele, how different the variation is across populations. So it's very high in East Asia. It can be between 40 and 60 or 65% here, whereas it's much lower in the rest of the world. Now again, we have already seen some graphs from Magnus showing the allelic variation in 2D6. It is a highly complex gene locus with a lot of single nucleotide polymorphisms and indels as shown here in group A. Then we have all these gene duplications in group B. And notably, you can have gene duplications of functional gene units, but also of non-functional ones. So just knowing a person has a duplication is really not enough. You need to know whether it's a functional duplication or a non-functional duplication. And then here in group C, this is really where the fun begins, where you have all sorts of hypergenes between the pseudogene, the 2D6 and the 2D7. So you can have a 2D6, 2D7, a 2D7, 2D6 hybrids. They can occur on their own. They can occur with others, with functional copies together. And you can easily imagine that these rearrangements can really interfere with the commonly used genotyping platforms. And so it is not just that these panel tests are often not really capturing copy number variation or do a thorough job in testing these variants. These hybrids and CNVs can really interfere with the platform as well. And so one limitation definitely is that these panels that are, or these commercially available test panels, they only test for the most common alleles. They often miss rare or population-specific alleles, and so you have to be really aware of what a test tests and what it does not test, and where your patient comes, and so on and so forth. And one question I get all the time is, how do you even navigate really all these different PGx tests that are out there? And so Busman in the CPT issue that comes out in August, it's already EPUB'd, gives you a flow chart of how to go through selecting a test. And so it starts testing, is there even a recommendation by CPIC, by another group, that allows you to make an interpretation of your tests? What should a lab test disclose? So if a lab test does not tell you what they test, or how they translate it into genotype or into phenotype, if they don't give you that information, say, thank you very much. I mean, you don't want this test. You really want to have transparency of knowing, so you can see, is the translation of what is tested correct, and are you testing, or are you having results for the variants that are important for your individual? Okay, now I want to give you a glimpse into GOLDILOKS. So this stands for Genomic and Ontogeny-Linked Dose Individualization and Clinical Optimization for Kids. Well, this is a mouthful, so this is why we just say GOLDILOKS. And actually, it is really just finding the right dose, not too big, not too small, just the right for your child. And just as a reminder to this audience, children are not just small adults. So just because a child weighs half or a quarter of an adult does not mean that you can cut your dose or your tablet in half or a quarter. So there are really different trajectories and expression of these drug metabolizing pathways in children. So we are using Atomoxetine as a prototype for precision therapeutics. So Atomoxetine is a selective norepinephrine reuptake inhibitor. It is used often only as a third-line treatment for ADHD. And although it is really a great drug if it works, the problem is, as you see here in the graph, it works only in about half the children. And so, of course, it's really a coin toss if you prescribe this drug. Does it work? Does it not work? So it would really be great to figure out what needs to be done to make this drug work in more children, or on the other hand, figure out in which children will it just not work, so that we are not really having these children undergo and try one drug, then another drug, then another drug, and having them these revolving door patients, because that is really strenuous on the child, on the parents. It is sometimes really scary to see on how many drugs these children have been, and then before they often hit our personalized medicine clinic, where we try to really use all that information, review all the drugs they are taking co-medications into consideration as well, and then use pharmacogenetics to pick the right or a better drug or combination for a given child. And so you have seen this here before, and I want to point out that between these poor metabolizers and these normal metabolizers, and there's one ultra-rapid metabolizer right at the bottom, the dose-corrected exposure or drug that is measured in plasma, there is a 30-fold range. I mean, this is quite a bit. And when we do a simulation to see which of these children are actually really reaching the desired range, which is this gray area here, you see here in red, it is actually the poor metabolizers that are well within this exposure range. The intermediate metabolizers are still making it into this range, although it is a little difficult to see. For the normal metabolizers, or this group where individuals have either one functional and one non-functional or two decreased function alleles, they just kind of peak into this range. But a lot of them are already under and out of this range. And individuals with two normal function alleles, they are not reaching the target range. And so is this a reason why this drug fails in so many children? Because we are just not giving them enough. And we also need to realize it's not always the poor metabolizers that are at risk. Here it's actually the poor metabolizers who have so far the most benefit. And so the question is, how can we really use that information to develop better algorithms and dosing schemes? And so what we have done here is we have repeated the PK study, which I have shown you data before on another 25 individuals, and then have used the data from these 50 children to develop a population PK model. And we are applying this model now to our GOLDILOKS study, which is a longitudinal study where we have 120 patients. We do PK on 2 occasions and inform it by individual information, including 2D6 genotype. And we also have extensive clinical information, because ADHD is a spectrum disorder. So the other question also is, are there certain ADHD phenotypes that are just better responders to this drug and has nothing to do with metabolism? And so getting a better grip on the ADHD phenotype will also hopefully help us in elucidating which children is a better responder group for this particular drug. And this is just a prototype of what this dosing model looks like. So we have body weight, height, gender, then the metabolizer information, but also obesity status. And in the United States, it is now over 30% or around 30% of children are obese. And so there are studies that start to show that really obesity status also contributes to variability. And so it is important to also account for this in these dosing models. And then we plan to also include not just 2D6, but also another pathway, 2C19, for example, which is a minor pathway. Now we still have variability we cannot explain. And so we are going to eventually sequence all these individuals to see whether we missed any rare variants or novel variants in these patients. So that will be taken care of. But still, what else is there? And so there is this distant enhancer SNP. So it was dubbed in the original publication that came out by colleagues of us with who we have collaborated. And so this enhancer SNP is a long distance downstream of the gene. It's about 114 kilobase pairs downstream. And so the idea is that this enhancer region is kind of flapping over, going to the promoter, and then impacts expression. And so now our question is how much of that variability is this enhancer indeed explaining? And is that percentage of variability that this enhancer might explain really enough to go through the trouble and genotype it, include it into all these translation models into prediction for the for clinical recommendation? And one really, really tough part is because it is so distant, how can we really link it up with the rest of the genotype? And what I mean with that is, if you have a STAR2 allele, which is a normal function gene, and you have, for example, a gene deletion, and we have shown that this enhancer SNP can be on a STAR2. In fact, in Europeans, most STAR2 have that enhancer SNP, but this is not true for African Americans. It's only a portion. This enhancer SNP can also be on the allele that has a gene deletion. So if you are heterozygous for this enhancer SNP and you have a STAR2, STAR5 genotype, on which allele is it? And so depending on which allele it is, that STAR2 might be called normal function or decreased function. And depending on which it is, it might be translated into a different phenotype group. And so we have devised a method which is long-distance phasing using digital droplet PCR, and we were able to show using this method whether this enhancer SNP here shown in green is located on the same as here a SNP in the gene. And so you see this orange signal. If it is on the same chromosome, you would not see this signal if it would be on the other chromosome. The limitations, however, are that you need a really high molecular DNA to do that, and this is often not available for study samples you have collected in the past. We have also shown using 10x genomics in conjunction with whole genome sequencing that this method can do long-range phasing. And here I show an example of a Coriell DNA that was genotyped as star 17 on one chromosome, a star 15 SNP on the other chromosome, and the enhancer we could put on this first haplotype block showing the enhancer is located on the star 17. And again, 15 is non-functional, 17 is a decreased function, so depending on where that enhancer might be, you have more or less activity. But this method here is expensive, still whole genome sequence data you need, plus the 10x analysis on top of that. But it works beautifully. And so what do we have in progress is three data sets. We have in vivo phenotype from 900 individuals, and we could not show that this enhancer is really explaining variability when we use the dextromethorphan urinary phenotype test. We are working right now on in vitro activity where we have 125 human livers. We tested for dextromethorphan and atomoxetine activity here. And as I will show you in just a second, the enhancer does seem to make an impact. And then what we will do in the upcoming year is to look in our GOLDILOKS pharmacokinetic study, which is probably the very best data set to show and see how much variability is explained in vivo. But we have to be a little bit more patient, so that will take a little while to come out. And so what we have seen in our tissue samples is when we take samples that have a star 1, a normal function, or a star 2 normal function allele, 7 and 21% of the variability using atomoxetine can be explained, which is actually really quite a bit here. Samples with the non-functional star 4, it did not really explain very much, but what's also striking here is that much more of the atomoxetine variability could be explained compared to dextromethorphan, which was really not very much, which goes hand in hand with our phenotype data, because this is where when you are in vivo, there is really a wide range even without a given phenotype, and if the enhancer only explains a small portion, we are probably not picking that up with that particular in vivo assay. So I am down to 9 seconds, and this is almost my last slide. So I want to give acknowledgments to everybody in my division of clinical pharmacology in our genome center, and want to stop here with this quote, and I hope that myself in my presentation, as long as Magnus, have really convinced you that pharmacogenetics is helping to improve drug therapy and has its own place in precision medicine. So thank you very much for being here early in the morning.